Mm. Okay.
Değerli katılımcılar, geleneksel Nurhan Aman konferansımızı bu yılda online yapmak durumunda kaldık. Ancak çok değerli bir konuşmacımız var. San Francisco'dan Dr. Chris Ames, özellikle spinal cerrahide çağdaş yaklaşımlar konusunda eminim ki yeni bir ufuk açacak. Bildiğiniz üzere Nurhan Aman konferansı geleneksel olarak her sene yapılmakta. Hiç ara vermeden bu sene 34.sünü yapacağız. Konular son derece ilginç. Nurhan Hoca'yı size tanıtmama gerek yok. Hepimizin bildiği gibi Türk nöroşirurjisinin modern mikrocerrahinin Türkiye'deki kurucusu, pioneer'ı. 1965'te bizim kliniği kurduğundan beri ondan aldığımız bayrağı biz de hem ülkemize hem onun çağdaş yaklaşımına yakışır bir şekilde en ileriye götürmeye çalışıyoruz. Bütün bu felsefe zannediyorum ki Türkiye'de nöroşirurji ailesinde benimsendi. Dolayısıyla bu ekolün bir ürünü olarak yine Nurhan Hoca'yı onun en çok istediği, ona gerçekten en çok layık olan bilimsel bir toplantıyla alacağız. Nurhan Hoca'yı hepiniz tanıdığı için çok fazla ayrıntıya girmeyeceğim. Kısaca Christopher Rames'i size tanıtmak istiyorum. Birçoğunuz tanıyordur, spinalciler özellikle. Kendisi şu anda UCSF'in beyin cerrahisi, Spinal Deformity servisini yönetmekte. Baş asistan olarak Kaliforniya Üniversitesi'nde çalışmış. Barrow'da özellikle komplike omurga cerrahisi üzerine eğitim almış. Biyomekanik laboratuvarında başında. Pek çok görevi var. Ancak bu özellikle komplike vakaların, deformitenin servikalde yeni cerrahileri veya teknikleri üzerine de yayınları çok. Son dönemlerde günümüzde artık cerrahi pratiğine pek çok alanda girmekte olan Artificial Intelligence ya da yapay zekanın da pek çok çalışmasının içinde Operatif Neurosurgery'sinin bölüm editörü. birçok ulusal ve uluslararası toplantı ve şeyde başkanlık yapmış durumda. Şu anda kendisinin 4 konu, bir tanesi video sunumu olmak üzere bize anlatma nezaketini gösterdi, kabul etti. Konuların hepsinin birbirinden bence ilginç. Soruları biz alacağız. Lütfen soruları bize atın o şeyden, soru bölümünden. Bu 4 oturumun her oturum sonunda veya 2 oturumdan sonra bütün 2 oturumla ilgili soruları alıp size yararlı bir webinar olacağını umut ediyorum. Dear colleagues, now it's my honor to present you our honorary lecturer of this Nurhan Aman's lecture, Dr. Christopher Ames. He has amazing studies, and he is going to talk about many complicated surgical techniques. I hope we all enjoy his lectures. And now it's my great honor to present you Dr. Christopher Ames.
Thank you so much, Professor Schegler, and it's such an honor to be presenting at the Neuron Augment Conference. So I've been really looking forward to this, and I look forward to spending the next 2 hours with you to talk about some of the highlights of my career from a research standpoint. And I'll be giving a series of lectures, and they actually recapitulate my whole career, really, which kind of started in tumor and ended up in artificial intelligence, and we're going in a different order, which is nice because we sort of start with where I am right now. My first lecture is going to be about the pathway that we followed in our research group from data analysis toward machine learning and AI, and how this may be transformative for adult deformity surgery. And I'll touch upon why we think that's important. I always like to start with an overview from a kind of a health economic standpoint of why this is important. And my data is on the economic side is biased toward the United States because that's the economic system in which I practice. But it's kind of interesting, and I know many surgeons around the world know sort of the valuation of the US dollar and can think sort of in US dollars. The cost of low back pain to the United States per year is around 440 billion US dollars. And that includes direct and indirect cost of care. It includes lost work and lost wages. So that cost is really significant when you think about it, even for economies that are as large as the United States. Inside of that, we have an epidemic, really, of adult spinal deformity. Not only are surgeons better at detecting it with long plate x-rays, but they become better at recognizing what would be the appropriate treatment, MIS treatment, open treatment, 3-column osteotomies. And this has resulted really in a big uptick in the amount of surgeries going on for the adults. The number of these surgeries has increased by about 157% in the last 10 years. And prevalence data indicates about a 60% prevalence of scoliosis when you look for it in patients over the age of 65, at least for minor curves. So this is something that's being encountered quite a lot. And then we counterbalance the increase in the amount of these surgeries with the results from these surgeries, and it creates a problem. So if you step back and let's look at how we're doing, at least from an open standpoint, and I know in Ankara there's great expertise in minimally invasive surgery. This really represents just open surgery results right now, but 70% major complication rate for these procedures. And these failures can fall within several different categories. And I'm just going to give you some background on what our failure rates are and why this is important. Mechanical failure, reoperation, their cost and effectiveness failure, or clinical failure. If we look at, for example, rod fracture rates, we see rod fracture rates that vary anywhere from 9 to 54%. And when we analyze the best study to date of rod fracture, we see that in the prospective NIH trial, at 5-year follow-up, the rate of rod fracture was 38%, which is amazing. That was the Bridwell trial out of it was NIH-funded trial. It was really a perfectly followed and in very granular detail with perfect, as near perfect follow-up as you can get. So this is real data. Also, when we look at PJK rates, we see very high rates when you look at all the different studies. This is from a large failure review we just did, ranging anywhere from a low, it doesn't get any lower than 9%, all the way up to rates in the 40% for significant PJK. And then reoperation rates that have an average of around, reporting of around 20%. So this is real data. When we compare this to how surgeons are doing in other specialties that are treating diseases of the aging population and diseases that, you would think are fairly significant operations, this is on the level, for example, of free flaps, and it's even worse in pediatric cardiac surgery. It's twice the failure rate of reoperation rate for an abdominal aneurysm repair. And then if we compare it to arthroplasty, it's particularly terrible. Arthroplasty, another very commonly employed operation for the older patients, reoperation rate's only 3.5%. So as large economies like the economy of Turkey, economy of the United States, that try to think, where am I going to spend my money to lift the health of my population? Adult spinal deformity is looking a little bit less attractive. When we look at cost effectiveness, we see that if you look at the incremental cost effectiveness ratio, which is the fifth line down here, this is typically used by large economies to figure out what they're going to spend money on, what's cost effective, and the threshold's usually around $80,000 to $100,000, sometimes even lower. We see that adult spinal deformity only becomes cost effective at 10-year follow-up if it's not reoperated on. If it's reoperated on within that period, it becomes cost ineffective, and the incremental cost effectiveness ratio goes way up. So failure destroys this cost effectiveness, and we have very high failure rates. What do we do to prevent failure? Well, we spend more money. So at my institution, this is a typical adult deformity case where you see multiple rods, we see double pelvis, VCR rod, we use biologics, we use ligament repair for PJK, we use cement, we use 2 surgeons, that's an opportunity cost for that surgeon, and plastic surgery. This is all to prevent reoperation, and we're spending more and more money. Many of these things, it might be particular to the United States, but many of the procedures that you see there on the left, they're not being paid for by the insurance companies. So the hospital or the surgeon are just doing that without reimbursement. And then you look at the particular position of adult deformity surgery up against other diseases of the aging population. It's estimated that the cost of caring for patients with dementia in the United States in the next decade will reach $1 trillion a year. As patients with Alzheimer's disease and get older and require a lot of healthcare expenditure. And then, of course, cardiovascular with stents, musculoskeletal with arthroplasty. So there are a lot of other diseases that are going to start to drain the healthcare system. And unless we can do a better job of getting better results in adult deformity surgery, we're going to have a problem. So how do we do that? Well, one way is enabling technology. And this has had dramatic effect around the world. It's changed the whole taxi industry. I'm not sure if Uber has infiltrated Turkey, but In the United States, it's everywhere. And it's really changed. So it used to be you would go to a big city, maybe Istanbul or New York City. You needed a very experienced taxi driver to show you where to go. Nowadays, someone right out of high school can get you to your destination just as accurately using enabling technology of navigation. And the same, I think, is going to be true of information technology in the future. In a similar way, I'm 55. When I was growing up in surgery, it was sort of accepted that younger surgeons might have a slightly higher complication rate than older surgeons, who were more experienced. Well, nowadays, at least in the United States, this is no longer acceptable. It's the patients and legal systems don't allow this. It's the same as when you get on a plane and you see a young pilot. You assume that that flight's going to be just as safe as with an older pilot. How is this achieved? It's achieved through enabling technologies where the experienced pilot, his learning curve and all that he's gone through already is somehow packaged and put back into the cockpit for the younger pilot. It's done through maintenance prediction, where they predict when the planes will need certain types of maintenance, wind shear prediction. A lot of this is done through machine learning-based predictions. And again, this is going to make its way into medicine, and I'll show you how that is. So if we sit back and you think of yourself being in kind of a think tank of how you're going to do this, how are you going to, you see all the problems that I've delineated, aging population, increased rates of deformity surgery, intolerance for unsafe procedures and complication rates, limited money, other diseases coming again to compete with deformity surgery. How do we keep this viable? Well, if you look at what's gone on with cancer, the way that they've transformed cancer care, and it's really well depicted in this book, The Emperor of All Maladies, they've transformed cancer care through data analysis and through registries, essentially creating massive registries of patients doing data analysis, genetic typing, receptor typing, SNP analysis, now expression analysis, and they started to cluster patients to form more effective clinical trials and to transform the way that chemotherapeutic trials and combination hybrid surgery and chemotherapeutic trials are designed. Well, now let's bring it back into where we are. So when I grew up and in neurosurgery, and maybe Professor Schadler can remember this, I remember that clearly about 30 years ago, when I was going through my residency, the senior attending surgeon said anyone that needs to use navigation is not a good neurosurgeon. They don't know their brain anatomy, or they don't know their spine anatomy. It was really all brain navigation at that point. And I mean, just think about how ridiculous that statement is today. It's become a key part of so much of what we do in all of neurosurgery now, and now it's making its way into arthroplasty, orthopedics, and all this. It's become a core part of what we do. And I would say we're really in the same area with information technology. So when we look at a patient now, sometimes I give this talk around the world, and senior surgeons say, I don't need the computers coming in between my patient and me, and when I'm talking to my patient about surgery. Well, it's going to be the same. I mean, the computers can look at a patient and much more accurately than a surgeon can predict how that patient's going to do with a particular type of procedure. This could be a minimally invasive procedure versus an open procedure, or it could be between open procedures, different osteotomy types, for example, and it can say how that patient's going to do. And that's incredibly powerful to bring that enabling technology, prediction technology to the point of care. And that's going to become mainstream. Well, how do we do that? Well, it's not just the surgeons. Medical device industry, which is so tied to everything we do in spine surgery, they're going to have to transform as well. They're going to have to develop solutions where they're no longer just selling you something that you put in the patient. They're going to have to sell you things that are software. And that actually is very difficult for them as an industry to think about how to do that, because they need to make money. Implant costs, there's constant downward pressure on implant cost. And they're trying to figure this out now. And, I do a lot of work with industry. They don't know whether hospitals and surgeons are going to pay for software. So they're working on this now, and they're also trying to figure out how are they going to support it in the operating rooms. So that's going on in the background, and that's very important for the scaling, the development of this technology, is that industry will take an interest in it and think that they can make money. Surgeons, for their part, have done a great job publishing a lot more in ASD research, and certainly the European Spine Study Group, the International Spine Study Group, many large registries in different countries. AO has done a great job getting literature out there on adult spinal deformity. But this hasn't transformed care so much. This is just giving us information. It's not really giving us information that we can use at the point of care. For example, here's a good sort of story about this. When I grew up on the lecture circuit anyway, you couldn't go to any lecture without seeing this sort of slide. And essentially what they were telling you was that if you achieve the sagittal modifiers that are linked to outcome via correlation analysis, that it would basically equal your patient doing well with a deformity surgery. Well, and this was one of the original publication. You can see the R-squared values there. Actually, when you look at it from a research standpoint, they're not even very high values. They're weak at best. Well, here's where we are now. So we reanalyzed this, and you look at the R-squared values now with close to 1,000 patients, and the correlation of the ODI to the SVA is nearly gone. And when you look at it after surgery, it's nearly non-existent. It's 0.05. Same for PILL. Same for pelvic tilt, even lower. So these guideposts, these compasses of how do we take a patient, this is what we've been publishing, right, for like 10 years. How do we guide surgeons now in what they do? Because this simple equation of sagittal balance equaling outcome is no longer real. It's no longer valid. So here's what we think that we do. We have to take a deeper look at surgeons, a deeper look at industry partners, and say we need to develop useful tools that surgeons can use. Not just keep pouring out paper after paper, but make tools. And so one of the tools is a risk score. You can't get credit in the United States to buy a house or a car without being given a risk score. But you could certainly have a lot of surgery done over the last, several decades without having anything more than an ASA grade given to you in terms of your risk for surgery. So we've been developing this concept of frailty for adult spinal deformity over the last probably 6 years or so. This is something that we started in the International Spine Study Group. And the idea was to develop a risk score based upon different categories of patient demographics, sarcopenia, mental frailty. You can see how frail this patient is in the clinic. And what we did was develop something called the Adult Spinal Deformity Frailty Index. We compared it for the first time this year to the Edmonton, which is a general measure of frailty. And we found that actually the disease-specific frailty score performs much better than the general frailty score of aging. And that's really not surprising. This was developed out of disease-specific data. Here's the frailty score. It's based upon 40 different data points. And what we did was look at different categories of frailty and correlate that to major complication incidence. This is important, for example, in choosing between minimally invasive surgery, where someone is likely to have less of an insult to their body, and you can model major surgery like a trauma. And if you look at that traumatic insult to a frail patient, you need to minimize the trauma of that insult to allow the patient to recover a reasonable amount of time without high risk of major complication. So it can help you choose between minimally invasive approaches and open approaches. The other thing that we did, and this is I like to tell everything like a story. Where did we come from and where are we going? So we datafied the procedure. So first we datafied the patient with frailty, then we datafied the procedure. We came up with an invasiveness score, And this invasiveness score was linked to risk of blood loss and was linked to operative time. And you can imagine that you can add in minimally invasive techniques to this. Endoscopic decompression or percutaneous screw placement, for example. And these would have lower point values and would be less of a major insult to the patient. Well, that works fairly well, but it's not as specific to many variables on the patient. I'm talking about 50 to 100 variable systems as some of the more advanced techniques. So now let's bring it more up to where we are right now. A great technique that's been used in a lot of medicine is unsupervised clustering. And I always tell my residents, if you really want to advance in your field, you should read half the papers in your field and half papers in totally unrelated fields. So read the New England Journal of Medicine, read Lancet, read in oncology, read in orthopedics. That will help you learn what are other clever people doing in other areas of medicine. So one thing that's been going on is something called unsupervised clustering, where they look at patterns in data and they take a fresh look at what they thought were old solved questions. And they did this with heart failure and atrial fibrillation and beta blockers. They thought beta blockers weren't effective. And when they clustered patients based upon many different variables, they found actually that was not true. That beta blockers were very effective, but for certain subtypes of patients. We've used this unsupervised clustering to develop a new type of adult deformity classification that's not based on the sagittal plane, which I showed you is really no longer very determinant of outcome. It's based on 50 variable systems that match patients and match procedure types and give you in real time a risk and benefit plot of the operation for that patient. But it does something even more powerful. Think about this scenario, and this is something that can be done with pattern recognition. So on the left is the inexperienced pilot trying to figure out what to do with this patient with many different variables, and they're trying to be good. They're measuring the patient. They're trying to figure out what is going to be the best operation for that patient. And on the right is what machine learning can do. It can say, this is you. This is the patient in front of you in the clinic. And these are the 10 patients that are most similar to that patient based upon x-rays. And then they can actually see how those patients were treated, how they were treated in Ankara, how were they treated in Bordeaux, how were they treated in Japan, how were they treated in the United States. And so that's what brings the experience of the experienced pilots back into the operating room of the inexperienced surgeon. Is this sort of pattern recognition? That's not possible, even for very experienced surgeons with great memories. It's not possible to say, this immediately reminds me of these 10 patients by name and pull them up. That's something that machines have to do. The next step on this journey is predictive modeling. So clustering sort of creates different subgroups in your data set that are very similar to each other, and so you can compare patient groups. Predictive modeling actually looks at that patient specifically based upon even larger numbers of variables and predicts precisely what how that patient is likely to recover from surgery and what complications that particular patient is likely to experience. This is where we started to combine our data sets with the European group. We started data sets in Asia and also in Latin America in the last few years. And this is what we can do now. So we can predict the individual risk of a major complication at every point from time point 0 out to 2 years. If you think about how in the past, when a patient was sitting in front of you in the clinic, how did you quote that patient that risk of surgery? Probably what you did is you went over here to one of the large papers that had been published, and you quoted them the average rate of complication that was from that paper. But now we can actually enter that particular patient's data in there and even the center's data and say this is the most accurate prediction that we can make for your complication curve after surgery. At my institution, we actually have the patient sign this, and it forms a medical legal document. Same for outcome. So what we can do, excuse me, is we can, in the past, we used to say, okay, we would go to a paper, and this is how the average patient was likely to do from the paper, so maybe that's how you're likely to do. But what we see is if we look at all the patients in these large data sets, the outcomes are very heterogeneous. So if we're quoting a patient, an average value as symbolized by the line, something that would make it into this paper, you're lying to 90% of the patients. That's not how they're likely to do. So what we want to do is we take all this data and we predict precisely how that particular patient's likely to do. And that moves outcome prediction from shallow medicine like papers to precise outputs that we can generate with artificial intelligence. And here's how this works. First, we cluster the patient, and we can pull out similar patients. We enter demographic information, we enter comorbidity information, we enter radiographic information, we enter disability information from the different scores. And then in real time in the clinic, while the patient's sitting there, you can enter the procedure data, minimally invasive versus open, and you get this risk of major complication, reoperation, readmission at every point from time point 0 out to 2 years. And you get a prediction of the patient's outcome across all the domains of health. And then you can give this to the patient and they can go home and think about it. And they can say, okay, this was my risk predicted precisely for me. And this is my benefit that was predicted precisely for me. It can also be used for benchmarking of quality. So I don't know how this is done in Turkey, but in the United States, they actually will compare you based on government reporting of major complications at your center. So many times the academic centers that treat the more complicated patients actually have lower quality ratings than small like hospitals that are doing kind of minimal procedures. If we just take PJK, for example, we see that if we use shallow approaches to benchmarking, you draw an average value across the different centers, you see that some sites in our research group seem to be outliers. They have high PJK rates, and some seem to be doing great. Like these are the best sites, right? But what we see is when we actually utilize a predictive model to calculate the expected rates of PJK, we see that some sites seem to be overperformers or doing well actually should have had even lower rates of PJK based upon their patient population. And some sites that where it seemed to be doing poorly or were higher than average actually were right where we would predict them to be. So the only way to do really quality benchmarking of quality for centers is to use predictive models, not average values. That's the shallow to deep leap that we need to take. This has tremendous impact as well in economics, where we can see if we utilize a computer model, for example, I mentioned how this is going to be impactful for economies, and we simulate operating according to what the machine predicts will be the MCID, or who will reach MCID, versus what the surgeon predicts. We see the machine beats the surgeon by about 684% in predicting who is likely to reach MCID. We boost our qualities if we use the machine decision-making versus use the surgeon decision-making. So anyone that thinks that machine learning and AI is not going to come to developed economies like Turkey or developing economies like India or even the United States that are really draining a lot of money from our health systems, you just look at this value here, where the machines are doing 684% better essentially in predicting who's going to benefit from surgery. We can predict the actual dollar value of cost and who's likely to be an outlier. And then maybe I'll stop this talk in another minute or two, but I just want to finish up with this. If we apply this at the population level, where we say, okay, in Turkey, we're going to draw a line. We're going to tolerate a 50% risk or 50% risk of complication, and we're going to insist that our patients have a 50% chance of reaching MCID. Then we take, if this is all patients, for example, in Turkey, this could be any country. We see that we're going to concentrate our efforts on this population. It's going to have a lower risk of complication. and a higher rate of breaching MCID. And this is what predictive modeling allows you to do on the front end before you spend the money on that particular surgery. So if we model this in the US, we see that we save the United States about $500 million US dollars in cost of surgeries that didn't make patients better. And then maybe I'll just spend another minute or two and talk a little bit about the future. One aspect of data science that we've been looking at, so if you do data science and AI, you're concentrating in two areas. So one is building interesting models that give valuable predictions to surgeons and patients. The other is finding new variables. So half your time is spent on making models and half is looking at new variables that might be even better. So one that we've been really looking at is physical variables, walking speed, 1, 2, 3, muscle bulk, get up and go, where we watch a patient and see how long it'll take that patient to stand up. And this is really interesting. So one of the things we love to do is to break paradigms, how people think. So we did it with the sagittal plane, but look at ODI. So if you look at ODI 40%, look at the variation in the sit to stand time across the ODI. So when we say that ODI is measuring disability, it's not really measuring very well physical disability because there's too much variable within the quartile. If you look at activity, we see same thing. Look at the variation across the 4-meter walk in SRS 3.5 physical activity. Look at promise. No correlation of promise physical function with time to get up and go. Doesn't work. Also inflammation. We've been looking at some patients become more inflamed as they get older. Well, that's linked to complication. So there are lab values that we're going to be collecting in the future. And these are not part of any of our current models that are going to probably change our ability to predict risk of surgery. And then cognition. When we look at our patient population at UCSF and we screen them for some component of delirium and dementia, we see that 53% of our adult deformity patients are cognitively impaired. So when you start looking for things, you start to learn things about your population that are quite different. Also, when patients are cognitively impaired, they have higher pain catastrophizing scores. And this is something that we're starting to look at as well. And then I'll just maybe finish with this. One of the most important variables is one that we haven't been collecting at all anywhere in the world over the last 20 years, and it has to do with genetic aging. So patients' tissues, we all know that when we look at people, we look at our patients, we look even at our friends, they're aging at different rates. Some people look great at 70 and some people look very old at 40. And this is going on with their bone, their muscle, their fibroblasts, all these things that are important for their recovery from surgery. And when we start to look at this in more detail, we realize that this would be important to use and include in our stratification tools, but this has not been done so far. So what we started to do in a collaboration at UCSF with Elizabeth Blackburn's lab is to look at something called telomere length. Telomeres are linked to genetic aging, and it's a good marker of your the cell division accuracy as you get older, which is one cause for patients kind of deteriorating. When we compared this to other risk stratification tools, we didn't see a difference in the ability of those tools to differentiate risk in our population. But when we looked at telomere length, we saw that telomere length, especially the patients that had major complications, despite being the same chronological age, were essentially 10 years older physiologically. And when we look at the shortest telomeres in our population, again, no difference in chronological age, the patients that had the shortest telomeres in the shortest quartile had 26 times the risk of a major complication. So we think that in the future, as we really start to stratify risk, when we start to choose between, for example, big open procedures and minimally invasive procedures like you specialize in Ankara, this is really going to be helpful to figure out, who who could tolerate the bigger operation and who may need a smaller operation, but this is going to lie at the genetic level. So I think I'll stop this talk at that slide, and I'm not sure if we want to take a few questions now, or pull up my other talk.
Amazing lecture. I think we all very much like to hear, and it's not only about artificial intelligence, but you open us new horizons like telomere length, and I think it's better not to operate with short telomeres. If you can choose the patients, that's very important. And there are many participants from all over the world, actually, from Colombia to India, but I think if the subject is about also deformity, we can go on for the next lecture, and then we can hear your comments on some of my colleagues' questions. Thank you.
Sure, my pleasure. And so I really appreciate the opportunity to basically show some of the work in my career. So my recent work has been really around AI. The work just before that was focused on trying to develop classifications and treatment methodologies that would be reproducible for the cervical spine. And I've combined my talks 2 and 3 together, so I think it would flow easier as we go from classification to treatment. And I would tell you, again, I like to tell the stories. I joined the International Spine Study Group, and Professor Schagler, you might find this funny. So when I joined as a neurosurgeon, they were trying to figure out, what's going on with these neurosurgeons starting to do deformity, and they said, oh, why don't you work on cervical deformity? Because they thought the neurosurgeon, they mostly treat the neck or something like that. It was pretty funny. So they assigned me to work on cervical classification, and that's how I started working on this, probably 10 years ago when I joined the International Spine Study Group. It's because I was a neurosurgeon. Chris Shaffrey and I were the only neurosurgeons in the group, and they said, oh, you must know something about the neck. Why don't you work on that? So that sort of changed my career. So how I came into it was like this. When I was growing up again in neurosurgery, we knew sort of like this patient. This was a kind of a familiar patient to us, chin on chest, not that common, but we would see them occasionally in the clinic. And then we would see some like very low grade cervical kyphosis. But it was patients like this, and like this maybe, and maybe like this, that we didn't encounter very much. And we had no way to classify them to figure out, how do you compare outcomes, what's really going on radiographically that produces these deformities. This patient with some sort of torticollis, but what's really going on, is this a torticollis or is this a scoliosis? And how do we figure out where to do the correction at the occipital cervical C1, C2, or is this something we should correct lower down? And this is what I started working on. Is basically I came into this and tried to make some sense of it radiographically. So as we kind of move forward through it, we wanted to develop paradigms that would explain this type of translated head deformity, where the external auditory canal is anterior to the thoracic inlet, but not a chin on chest. This is not really a chin on chest type deformity. And then to develop treatment paradigms for this patient. This is a patient you may see walking around. You might not even think this patient has a significant cervical deformity. This was a PJK patient that had an AIS procedure, and she was complaining of a lot of neck pain, fatiguing neck pain at the end of the day from holding her head up. And she's masking a lot of her deformity through compensation. And then these patients where the ear is not even translated, I use the external auditory canal as a surrogate for the center of gravity of the head. And this patient, you might think, oh, this patient has no deformity. This is exactly like, for example, a flat back patient that is retroverting their pelvis completely, where you can't even tell that they have a sagittal plane deformity. But when you ask this patient to assume a position of comfort, this is what happens. So you say, assume a position of comfort, and they put their head forward. This is a relaxing their compensation. So we have to also figure out ways, as we're putting together this classification system, where we can quantitate the compensation. So find essentially the pelvic tilt for the cervical spine. And you guys know I like to always start out by placing everything in the proper public health context. And this is what, again, where we started. So we started looking at how much does cervical deformity affect the patients? Is it a serious problem or is it not a very serious problem when you look at EQ5D, which is a good measure of general physical health? And we see that cervical deformity falls down somewhere around emphysema and even low vision or blindness. So this is something that is really impacting patients' health, and it's worth studying and learning how to treat it. Then we took a deep dive. I did this study actually with diffuse synthes, and we took it because they had access to industry databases that I didn't have as a surgeon. And I wanted to know what was going on with utilization of implants around the world for deformity versus degen in the cervical spine. And look at this, the amount of surgery for deformity in the neck has been dramatically increasing, 1,500% increase. And when you compare this to non-deformity cases, deformity has been growing at a much more rapid rate. So when you look at the impact on health and you look at the rate of growth, this is an area that we know needs to be studied. The other interesting phenomenon going on in cervical deformity is that the most rapidly growing areas are actually the older patients. So it's not the 40 or 50-year-old necessarily that's having these bigger procedures done. These are patients in their 60s and even in over 75. You know, look at the number over 75 that were having surgery back here, and now look at it, or 65 back here. So this has really changed. They have poor bone stock, they're frail. Again, this is an argument for finding, and this is where we really need minimally invasive surgeons and endoscopic surgeons, try to figure out how can we develop less traumatic insults to these older patients that have these problems. So when I was trained by Volker Sonntag at the Barrow in spine surgery, and when I was growing up, all he ever said, you know, from a deformity standpoint in the neck was, you know, there's a little kyphosis, we need to treat it. That was not based on any quantification, nor was it based on any outcomes data that actually even treating kyphosis made any difference. And there was this old paper by Hardiker written in 1997 where he talked about this plumb line, and he started to measure normative values of the angles in the cervical spine. And what we found was actually in most of the cervical spine, it wasn't all that lordotic. So that was one interesting thing. Most of the lordosis was actually up here. And he commented that this plumb line usually lies about 1.5 centimeters ahead in front of C7. So true, you know, this is true story how the classification was developed. I read this paper, and I was also working with Frank Schwab, who was working in the thoracolumbar spine, and I thought we can probably develop something pretty similar here for the neck. So we, you know, analyzed these segmental values, and we looked at this number, and I started to think this concept of a plumb line might be more interesting than actually lordosis itself. So as I mentioned, you know, the older surgeons that when I was growing up, they were concentrating more on segmental kyphosis, and now it seems like maybe we should concentrate more on balance, head balance. So that's where it all started from. And then when we started looking at the data, we started collaborating with Ibrahim Obeid in Bordeaux. And we saw that actually in his study, 32% of patients were kyphotic at baseline, and they were asymptomatic. So kyphosis itself, overall cervical kyphosis, was not an indication or an immediate trigger for something abnormal going on. That was quite educational as well. And what we wanted to do was develop something similar to this paradigm. So to develop a clinical impact classification where we had sagittal modifiers and deformity types, and I'll kind of show you how we did that. So first we wanted to figure out what is a normal cervical lordosis. So how do you figure that out? It probably varies with the individual. And what we found was that the cervical lordosis is actually linked to the pelvis. So if you have a higher PI, you're going to have a higher T1 slope, and that's going to mean more cervical lordosis. If you have a low PI, the whole spine is going to be flatter, and the neck's going to be flatter. And these patients may actually be the ones that at baseline may even have a little bit of kyphosis. Now, I know it's mostly a neurosurgical audience, so I don't want to ignore the other major creator of the cervical lordosis, which is actually the skull base angle, the clivocervical angle. So you can have abnormalities or variation in the clivocervical angle actually work down. So you can see the value as you work your way up the chain of correlation. It doesn't go more than half. We think half of this, or maybe a little bit less, is coming from the top down. It's a clivocervical angle that's set at birth. You know, the clivus docks in the skull and the sacrum docks in the pelvis. And so those two things probably determine in large part what would be the normal value for that patient's cervical lordosis. The other, finally, is the way that the neck docks into the thoracic inlet. And there's probably some variation there as to how T1 sits within the thoracic cage. So it also made sense to us that just like as you translate your whole trunk forward, you generate energy expenditure. As you move your head forward, you generate energy expenditure down here at the cervical thoracic junction. It's essentially cantilever load. So true story again, the ISSG cervical database was not ready. We were just starting to collect some cervical patients. So I went in my UCSF data and I'd realized that patients were coming back to see me. I was, still kind of early in my practice, but I'd noticed that patients that were coming back to see me who were solidly fused, some of them still had a lot of neck pain, and some of them were perfect. And I couldn't figure out why some still had a lot of neck pain and some didn't. And so I thought this plumb line may be explaining it. And so we did a study, which is now one of the top 10 all-time cited papers in neurosurgery. And we published this first attempt at developing this plumb line. And we looked at a variety of different plumb lines from the center of gravity of the head, C1, C2. We felt C2 was probably the most easily measured. There wasn't a whole lot of difference between them. And we developed this correlation analysis, which now is probably, in retrospect, should be replaced by AI. I'll talk about that. But we developed this correlation with the neck disability score, which is very much like what Schwab and Glassman had found for the thoracolumbar spine. Same for PCS. And then we did a regression analysis. We found a threshold of about 4 centimeters. Again, it's kind of funny that it's 4 to 5 centimeters in the lumbar spine, and it was 4 to 5 centimeters as well in the cervical spine. I'm not sure why that is, whether that's just a coincidence. And here's the kind of the idea. So I like to come up with a story for this animation. So you can imagine that this patient, had some degenerative disease in the cervical spine and maybe underwent a 1-level ACDF that was maybe not lordotic enough at the cervical thoracic junction, and they were compensating. And then maybe they developed some neck segment disease and they were extended, but when they were extended, they weren't lordosed, and they had a posterior operation. And then maybe they developed a compression fracture here in the upper back, where their head drifted a little farther forward, their T1 slope increased a little bit more. And we can see that now the patient's really having to compensate to get the head back to normal. But they're still able to hyperextend and use all their muscles to get their head back to level. And then eventually they reach a point where they can't compensate, and they've decompensated. This is, again, very similar to what we see in sagittal balance. So this made us start thinking we could develop a PI minus LL parameter for the neck based on the T1 slope, where essentially the T1 slope determines the amount of lordosis that's required. And we can see here, if the T1 slope doesn't match the cervical lordosis, you have to compensate. This is kind of what I just showed you in the past. And so we looked at T1 minus CL and came up with a value of 21 degrees that was linked to disability scores. And that's where that parameter essentially came from. This was then validated by Hanjo Kim at Hospital for Special Surgery. He found the same thing, actually even higher R-squared values, which made us think, we're on the right track with what we're starting to look at. We then looked at T1 slope. We were trying to develop an idea of when surgeons needed to get long plate x-rays on cervical patients. So this is a good take-home point from the lecture. If your T1 slope is more than about 30 degrees, it usually means there's something going on down here that's producing the cervical deformity. So maybe not everybody needs a 3-foot x-ray in the cervical spine, but if the T1 slope is high, you should get a long plate x-ray. Then Demyelination in our group started looking at chin-brow vertical angle, and he developed this concept of the slope of the line of sight along the inferior margin of the orbit and the Frankfurt plane. And this is important because previously, chin-brow vertical angle was determined by clinical pictures. We didn't have clinical pictures in our database, so we needed a radiographic surrogate for that. And he found correlation of the chin-brow vertical angle to neck disability scores. This was the first publication of this. And he found a sort of a sweet spot between -4 and +17. And when you exceeded those values, the disability scores really increased. So that's where our CBVA modifiers came from. And here's just some examples, CBVA modifier 1 versus 2. And you can see that I started with those pictures of all the different, patients, and now we're starting to kind of understand, what's going on, at least in terms of our ability to classify them. And then we wanted to develop this pelvic tilt for the cervical spine, this compensatory muscle recruitment, and we looked at the C1, C2 lordosis. And we found that when the C1, C2 lordosis was more than about 30 degrees, it led to disability scores and neck pain. And so this became kind of our pelvic tilt parameter. Very importantly, this is a parameter that when you plan these surgeries needs to be corrected. If you don't correct enough of the cervical spine to allow relaxation of the C1, C2 angle, it's very similar to correcting the lumbar spine without allowing the pelvis to correct, then patients still have neck pain. And then finally, again, bringing it back to neurosurgery a little bit, we wanted to investigate the relationship between cervical myelopathy and the sagittal plane. How important is it, for example, these are questions that we're still trying to answer, to correct the kyphosis to maximize the improvement for surgery for myelopathy? In neurosurgery, and in orthopedics too, honestly, the inclination was all you needed to do was decompress the spinal cord. You didn't have to correct the kyphosis quite as much, maybe because that was a much more dangerous procedure, and patients improved just with correcting the compression. So these are some open questions that we're still trying to answer. There seems to be some relationship of kyphosis to demyelination and apoptosis. This has been well known and studied in congenital thoracic kyphosis, for example. The orthopedic surgeons that treat pediatrics, they know that high deformity angular ratios themselves can lead to myelopathy, and the idea was cord stretch itself could raise pressure in the cord. The work done by Charles Kuntz showed that not only does kyphosis, but actually translation of the head lead to increased cord pressures. So again, there's something going on with the sagittal plane and the spinal cord itself that goes beyond just compression of the cord. And so we collaborated with Michael Failings from the AO North America group in a study I did with Justin Smith. And we found for the first time that the C2, C7 SVA actually correlated with myelopathy scores. Finally, how do we determine the apex of the deformity? I'm going to show you a quick and dirty method. So if somebody throws a film up and you're trying to figure out where is the apex, which is important, look at the relationship of the C2 slope to the T1 slope. If the C2 slope is low and the T1 slope is high, the deformity is usually below. If the C2 slope is high and the T1 slope is low, that's usually an isolated cervical deformity. And this is a paradigm that Demyelination in our group helped to develop. And then finally, if both are elevated, then you usually have a mixed deformity, and you may need to take this instrumentation down a bit lower in the thoracic spine to do the correction. So this is where we ended up. This was our deformity classification that we published. Essentially, it has apex location on the left, and then the clinical impact modifiers on the right, where all of these are linked to clinical impact. And importantly, all of this sits on top of the deformity morphology below. So it all sits on top of the Schwab classification, I like to say. And I'll show you sort of the next horizon. This is work that, based upon our work using clustering in the thoracolumbar spine, Hanjo Kim and Virginie Lafarge in our group started to apply clustering to the cervical spine. And when they allowed the computer to look at patterns in the cervical deformity patient population, the computer independently came up with us basically having 3 groups. So I always think this is so crazy, because the computer wasn't given any information, and it basically went into the database and it said, okay, basically you guys have flat neck patients, and these usually have fusions from C2 to T3. You guys have focal cervical deformity patients, where usually it's an anterior procedure in the cervical spine. And then you have group 3 patients where they have very high T1 slopes, and these patients are usually taken down much lower. What's so interesting to me about this is that this was exactly what a large Delphi approach found. This is work I did with the European CSRS. This is exactly what the humans in the European CSRS found. Nearly identical classification to what our computer found in our group. We can talk about that. What are the issues with classification? I think classification is going to move more toward the machine learning and clustering, and more away from the R squared that my original classification was based on. But there are some major issues. So one is, when you develop a classification, the classification that you apply to this patient with a focal deformity, the concerns of this patient are probably more radiculopathy, maybe a little bit of neck pain, are very different from the concerns of this patient. So it's hard to have the same classification where you're trying to develop different treatments where the patients are so different. The other problem with developing classifications that are based on disability is that high complication rates in these surgeries that I'll talk on in the next part of the talk confound that. If the patient has hand weakness or shoulder weakness or some other complication, that's overwhelming their disability scores, and it becomes harder to build classifications off of that. And then finally, as I mentioned, one of the biggest problems is we don't have an adequate HRQOL instrument for this patient. And so we've been looking at adaptation of the SRS-22C for this type of patient, where we can build in more cervical specific concerns. So I'll just kind of bridge the gap a little bit before I move on to the osteotomies. When we evaluate these patients, we look very carefully at the ear, and we also look at the low back. Many times these patients have flat back. We look at the T1 slope, and we look at their angle of gaze. Here are a couple examples. This patient, if you think about this, and I know it's a neurosurgical audience, so I want to try to explain how a deformity surgeon would look at this patient. So a deformity surgeon would say, this patient has no impact in the appearance domain. So when you look at this patient, they don't have any clinical deformity. But look at actually what their x-ray shows. So this pattern of deformity in the upper cervical spine can produce myelopathy, but it doesn't impact the appearance. And again, this gets back to my very first slide. So high cervical kyphosis can be completely hidden. Cervical thoracic apex deformities cause impacts across all functional domains of health. And this is usually with an apex right at the cervical thoracic junction, usually around C7. Remember this type of patient, translated head, but not chin on chest. This is a T1 minus CL abnormality. So the deformity lies in the inability to match the cervical lordosis to this high T1 slope. And that's what produces this translated head type of manifestation.
Okay, and now relax a little bit.
And then we can have this,
Okay.
this
And now
type of
look straight
patient
again.
that actually has a normal cervical spine, but
relax.
has thoracic kyphosis. It has fatiguing head imbalance related to that. And then finally, this patient that seemed to have maybe a torticollis, but this patient's actually a cervical thoracic scoliosis patient. And this is from, adolescence. This patient presented to us with appearance-related complaints. You can see the head is offset, and he wanted his appearance fixed. He actually didn't have much in the way of neck pain. And then finally, this type of patient, where this patient, true story, wanted to have surgery to have a better appearance on the dating sites, on the social media, dating sites. He didn't like his head tilt. So what's wrong with this patient? This patient had a hemivertebra. So this patient actually had a resection in the lumbar spine with spontaneous correction of the cervical deformity. So that's why it's very important to put all of this on top of the Schwab classification. And then these multi-regional deformities that can produce these sort of mixed pictures with impacts across, again, all domains, including appearance. These patients usually will have, if the PILL is high, these patients will typically have a lumbar osteotomy first, and this patient actually had three column osteotomies for his final correction of his appearance with Ankylosing Spondylitis. We evaluate the patient supine, both on the side if they have a sagittal or a coronal deformity, as well as pure supine. We evaluate them over time, see whether they have an ability to hold their head up over time, see how flexible their deformity is. And then we ask them to, our new concept is this concept of extension reserve. I use this a lot in my PJK patients to figure out who's going to need surgery. If the patients are maximally extended at horizontal, they usually will need revision surgery. If they still maintain some ability to look up, usually those patients have enough compensation left that they won't need an early revision for upper thoracic PJF. And then this is our patient from before. Just want to show you, this patient is actually a cervical deformity patient now. She had a prior cervical or prior thoracolumbar surgery. You can see her sarcopenia and her wasting. This is a sign called the Benzel sign. Many of these cervical sagittal patients have hypertrophied muscles in the trapezius region. This often doesn't get better despite correction of the cervical deformity. So it's important to inform your female patients. This hypertrophy that develops often doesn't go away. And then we look very carefully for signs of anterior muscle migration in iatrogenic deformity. This has to be repaired at the same time. If you don't dorsally translate the musculature, these patients will not only be unhappy with their wound, but they're going to be unhappy with their neck pain as well. The muscles are a very important part of what drives a lot of the neck pain. For correction, we actually analyze the correction angle with the patient in a position of comfort. So this is going to make this point. You see that if you were to calculate this correction angle with this still in a hyperextended position, you're going to underestimate the amount of correction angle that's required to correct the occipital, to fully correct not only the translational deformity, but also the compensation. So we ask the patient to assume a position of comfort where we see this is relaxed, and this is actually the osteotomy angle that will be required to fully correct this patient. With this still in a hyperextended position, when we do corrections now, because we've seen that in the history of doing realignment surgery, we often got this really wrong. From our thoracolumbar work, we saw that surgeons were not able to accurately predict postoperative alignment just based upon the preoperative x-rays and planning alone. We've been using custom rods in the thoracolumbar spine for a few years. This has increased our accuracy quite a bit compared to historical data. And now we use custom rods for the cervical realignment because it's even harder, because not only are you dealing with a mobile occipital cervical region, but you're also dealing with a mobile spine down here. And so the custom rods that take into account some of the reciprocal changes that you're going to see down here can be very helpful for realignment planning. A little bit about outcomes. This is from the only study really done on a large data set of 1-year outcomes in neck deformity. We see that we're moving them fairly close to the MCID, but not completely. They are improving, but they're still having quite a bit of neck pain, unfortunately. Their EQ5D is also improving, but they're still, we're not getting as much of a jump as we had hoped. So I'm going to move directly now into the osteotomies, and I'll do lecture 3 right now, and then we can maybe take some short questions while I change to lecture 4. We started out and we said, okay, we have to explain all these different head positions radiographically. We have to understand what's driving these patients' disability, and this is going to give us some alignment targets and some things to think about as we do correction. But then we also realized that we had no language for the corrections that we were doing. We didn't even know how to talk about osteotomies. So very early on in this work, we developed this release and osteotomy classification. Some of it is soft tissue release, and some of it is actually an osteotomy. It moves all the way from just ACDF and facet capsule release or type 1 osteotomy in the cervical spine up to what's kind of like a ponte, corpectomy, uncovertebral osteotomy, and I'll show you some examples of these. And then type 5 osteotomy, the opening wedge, that's used very rarely these days. We usually use the closing wedge because it's a bit more stable, and we don't have to fill this gap with bone. We can just do a closed bone on bone. And then cervical VCR is not used very much. It's essentially a very radical anterior-posterior approach. And here it is in larger form. If you're interested in more detail on how we did this, you can just look at our publication. The most important thing when we realign any patient, I call this osteotomy type 0. This is essentially avoiding deformity. So in patients where you're just doing an operation where they don't have significant stenosis, you can dial them back before you even start. And I try to put the back of the head the same level of the thoracic apex. If they have compression, then you do this before you put the rod in. It's very important when you position the patient before you put the rod in, that the back of the head is at the same level as the thoracic apex. If not, this is where a lot of iatrogenic deformity comes from. When we do the corrections, we put our hand on the back of the head, and after the correction, we want to see the hand is at the same level of the thoracic apex. It's a quick and dirty method to make sure your correction is adequate. For low-grade focal deformities, this would be the type 2 AI-based machine learning classification. We do anterior approaches, sometimes with combined posterior approaches, depending on the bone quality and the fusion. And we actually analyzed this in our group. There were some strong advocates for the posterior approach. There were some strong advocates for the combined, some strong advocates for the anterior approach. And so for these type 2 deformities, these focal flexible deformities, we wanted to look at what was the optimal treatment. Well, there's nothing like research to answer a question. Anterior approach for these type 2 cluster deformities seem to be much better. So simple anterior approach, better neck pain scores, better correction, and better NDI scores. So for these flexible anterior deformities, even ones that can be very severe, anterior approach can be quite helpful. For semi-rigid deformities, we typically use a type 2 osteotomy and do an all posterior approach. Although depending on bone stock, you can certainly fill them in. But you can see with a type 2 osteotomy in the back, and we're able to get some opening here in the discs. And here's an example of this, typical type of patient. And I'll just play this out. The most important technical pearl for these type 2 osteotomies is you have to remove the entire superior articular process. If you're going to close these down without removing the superior articular process, you'll drive that piece of bone into the nerve. So we spend a lot of time to dig that out when we're completing our osteotomies. There you can see the complete nerve root completely filleted open. Pedicle screws can be very helpful here because there's not a lot of lateral mass left after you do these procedures, these type 2 osteotomies. And then we do sequential cantilever reduction, working our way down from the cervical spine into the cervical thoracic spine. If we're going that low, just kind of slowly working our way down. And we're constantly lifting up the head a little bit, then doing a little bit of cantilever, lifting up the head, doing a little bit of cantilever. And you can see the pedicle screws that we use, the cervical pedicle screws that we use for this. Why pedicle screws? Well, without pedicle screws, you can have this phenomenon. If you're trying to use cantilever and you're using lateral mass screws, that doesn't work. I wish I could tell you that we did that just to show you that, but unfortunately, that was a real case. And so we've switched over to really all pedicle screw constructs when we can. These are much more powerful for cervical deformity correction. We typically use navigation, but if you don't use navigation or you want a freehand technique, the best one I found was from my friend Sang Lee, who's now at Hopkins, who taught me this technique. It's called the slot technique, where essentially, starting in the middle of the lateral mass, at the top of the lateral mass, you drill essentially a slot out of this bone. You basically drill out this cube. And I'll show you a video. This is a great freehand technique for these pedicle screws. So essentially you drill out this sort of triangle. So you come down kind of in the center of the lateral mass, maybe a little bit medial, and then you drill this sort of triangle here, and the gear shift will follow this in. It actually works really well. And here's just an example from his technique video showing how he drills this freehand cervical pedicle screw trajectory. And then he'll use a gear shift to go in that way. And if you aim essentially very medial, because the medial cortex is much stronger than the lateral cortex by the vertebral artery. And it's obviously better to have a medial breach in this location than a lateral breach into the vertebral artery. I use navigation, usually when at all possible. And we can even navigate our screws for this. The reason I was spending so much time on the instrumentation technique is that cervical pedicle screws will really transform your ability as a cervical deformity surgeon. It's much, much more powerful for correction. Sometimes pedicle screws are not enough, and there are some newer methods of fixation. You can combine this with either an anterior posterior, like you fill in an ALIF after a long deformity correction, or Tepusintes now has something called multi-point, which is another way to connect to the lateral mass. But you have to realize, even with pedicle screws, the bone stock is sometimes not enough, and you should fill these in anteriorly. For the patients that have an iatrogenic deformity, prior fusion, a very rigid mid-cervical type of deformity. So this would be a type 2 rigid in the AI classification. We use this mid-cervical type 4 osteotomy combined with a type 2 osteotomy in the back. It's very useful for myelopathic patients with a rigid mid-cervical deformity. So this is a PAP, posterior anterior posterior, with a type 4 osteotomy. This is it diagrammatically. And we pull the spine into lordosis from the front. This is this case before we started using pedicle screws. Lateral mass screws were placed. You can see the osteotomy. And then the anterior osteotomy being drilled. And this is entirely through a fusion mass. So we can drill out the old bone, or you drill out the cages, and then we work our way around. You can see some motion starting to occur there through the fusion mass with a Penfield 4 protecting the vertebral artery. In practice, you don't usually have to go all the way to the vertebral artery. You can crack it and crack that lateral bone. It's a little bit safer. And then we can get some nice segmental lordotic mobility there. And here's again, just a picture of the mobility. And then we leave a gap in the plate and we contour the plate, and then we pull the spine up to the plate. So you have some grafts in, they're not super tight grafts, or they're not, they fit the space well, but they're not over distracted. So there's still some mobility, and that allows you to pull the spine up in the front. And then we apply a little posterior compression. And so that's how that works for a mid-cervical kyphotic deformity. And that was that patient, actually. And then finally, to talk about the 3-column osteotomies. Unfortunately, these are being increasingly utilized, especially because we see so much iatrogenic deformity going on. A lot of these are rigid PJF patients. Some of them are prior cervical patients that have rigid DJK. And then very occasionally we have AS patients or those types of patients that require this 3-column. We developed the first set, we developed it with DePuy actually, but now every implant vendor has this sort of similar set. And I want to just kind of show you these conical taps. These are very useful. How did we come up with this idea? Well, we started using lumbar taps to actually do the decancellation. I'll show you a video of that. And then we thought, well, we could actually develop these little short conical taps to do the decancellation. And so this is it diagrammatically. Rather than using a high-speed burr around the nerves, we use these manual conical taps that we can turn very slowly to do the decancellation. It actually works pretty well. And otherwise, it's very similar to a lumbar PSO. And then for the correction, we do a manual correction on the head. We now use the levo attachment to the Jackson table to do this. In the past, we used to do just freehand correction. And so just show you some video. This is us dissecting the lateral border of C7 with a Penfield 1 after the laminectomy's been done. I just make one other comment is these patients are usually stable in the halo. I think I have a computer crash here or something. Oh, there we go. Sorry. Slides were delayed. Sorry. Let's go back. Yeah. This is the video of us using the original, where we got the idea of us using a lumbar tap to do the decancellation. That's where we got the idea of actually developing the conical taps to do this. And then to do the correction, we're going to manually lift up the head. This is kind of the old style. And this is what it kind of looks like with the nerve roots in a single foramen. And this is the amount of dural buckling we get. And correction. This was the patient with the chin on chest. And then this is the use of the conical tap in the thoracolumbar junction, or sorry, the cervical thoracic junction. You can see it just kind of goes in. Once that goes in, it's mostly decancellated. And then we use a box chisel to complete it. And I'll show you the box chisel being used. It's a mini box chisel. It's based on the Lenke set from Medtronic, but it's just miniaturized for the cervical thoracic region. And you can see we work in teams. So that's my partner, Vedat Devran, on the other side. He actually went to Ankara Medical School. We do a lot of these cases together. And then we use racks where we're trying to stabilize the spine. Sometimes when you're doing them in the cervical region and the head's in the halo rigidly attached to the bed, you don't need actually to apply the stabilization. But as you get lower in the thoracic spine, like at T2, T3, we like to apply the racks to hold it stable. And these work much better than temporary rods, actually. Why? Because you can go up and down, you can easily tension, distract, etc., without having to trade out and retorque and distract on a rod. So it's a much better technique. And then central impaction. This is obviously a PJK case to break the middle column. And then here I just wanted to show you, this is a good view of the closing. So you can see that the spine's actually quite stable. The patient's well padded on the thoracic pads. And then we have their head in the halo. And this is a way we used to correct them. And I'll just show you the shortening going on as we correct. That's actually the real time, the head being lifted and the shortening going on around the spinal cord. Nowadays, we use this. I don't have anything to do with this company, but this is very helpful for cervical deformity. It's a levo attachment. It's essentially like power steering. So you can reach through the drapes, lift up a little bit, let go, do a little bit more correction, lift up a little bit. And rather than detaching and reattaching the halo, it's very useful. We get about 19 degrees of correction with a C7 or T1 PSO. And we can even use this for cervical thoracic scoliotic deformity. And I'll show you how we use the racks for this. This is for asymmetric correction. We use these racks. So we've already done our sagittal correction a little bit. And now we're going to hold one rack rigid while we compress the contralateral side. And again, we slowly move the head a little bit while we're doing the compression. And this allows us to correct the coronal deformity. So these racks very useful for not only sagittal plane, but also for the coronal plane as well. And we use 3 rods, and you can see his head position much improved with the correction. Now to just go up in level of complexity, some of our more severe cases. This patient actually had, and this is another pearl. If you see a patient like this with a very severe thoracic deformity that's long-standing, we thought when we took this patient to surgery, we were going to be able to unwind the head because it should be flexible under anesthesia to be able to get in our cervical instrumentation, but we couldn't. The head was rigid. So we actually had to do an osteotomy first just to flex her head. So we actually cut one osteotomy, flexed her head. That allowed us to get our lower cervical instrumentation in, and then we closed it again to do the correction, and we had to do another one for full correction. So these long-standing deformities can be very difficult. This one needed a double VCR and a lumbar PSO for her correction. And you can see we just took her 5.5 rod all the way into the cervical spine with cervical pedicle screws for her correction. The most difficult of these deformities are the AS patients with contractures. It's very difficult, at least in the United States, where we don't treat a lot of AS, to get our orthopedic surgeons to be very cooperative with us in terms of the arthroplasties and releases. This shows you a case. This patient actually we saw in 19. He was afraid of surgery. He didn't come back until 21, at which point he couldn't stand and he had severe contractures as well. This was him when we received him. And I'll show you the different stages of his surgery. Here you can see the patients in the OSI table built up very high with rolls to allow us to position him. He first had a femoral head resection with traction. Then he underwent a double VCR, and then he underwent an L2 PSO. Here are his progressive improvements in his deformity and his post-op. He's still waiting for his arthroplasty for his femoral head resection. I never like to give this talk without spending the last 3 minutes on the complications. These procedures have very high complication rates. The worst complications we see are neurologic and DJK, and I'll talk about each of those. The neurologic we see are mostly hand weakness. So when you're in cervical degenerative surgery, the nemesis of our existence there is the C5 palsy. Here for deformity correction, our nemesis is the C8 palsy, and it has to do, I think, with traction. We think maybe it has to do with the way the C8 nerve is somehow tensioned in the thoracic inlet during these corrections, or there's some shortening that goes on in long-standing sagittal deformity. Here's a case, chin on chest, patient. This is what we see. They just get severe hand wasting. They're very miserable. So they're much more miserable than a lumbar patient, for example, that has quadricep weakness after a lumbar PSO. If you can't use your dominant hand after a cervical thoracic correction, that's just misery. Unfortunately, this is from my series of 100 of these surgeries. At 1 year, 28% did not improve. So unlike C5 palsy, C8 palsy just doesn't improve quite as much, unfortunately. Mechanical failure is also a problem in these patients. Junctional failure rates in my series of 18% and high reoperation rates. It's mostly situations like this where you see some failure at the bottom, or a patient like this that developed DJK and ended up being extended. We've been using ligament augmentation for PJK for several years, and we recently started to use it for DJK prevention, where we sort of tie it into the distal end of the construct. In a very similar way, we're imparting an extension moment at the bottom to help prevent this sort of ligamentous failure. Bony failure we prevent by angling our screws up into the end plate below, can be helpful. So they fail in any number of means. You really need to protect the soft tissues as well as the bone to prevent a failure. So I think we're pretty much on time. That's the lectures number 2 and lecture number 3 are now done.
Thank you, Dr. Engs. They were very, very much. I enjoyed all the lectures, and really every subject you emphasize many important things and many things that we are afraid to face in our practice. You know, cervical region is, of course, used to be our neurosurgeon's territory. It was like a promised land for us, but you know, when it comes to deformity, and we really not much encouraged to correct it, and your cases are excellent, and I really admire. There are many things that we should discuss, but first I want to go back to your first lecture, and I think the artificial intelligence really is going to be in our practice much, much more than it has been. But what do you think? I think it's still a tool. What I mean the sense of surgeon, the sans clinique en France, you know, and the other things, we cannot take into consideration all the parameters. That's true. We are not computers, but the sans clinique we used to say, or you smell the patient, you may much better know than the machine. But still, I think it's a very good tool. It's a very good tool because as medical doctors, as surgeons, we cannot calculate all these parameters. And the thing is, the artificial intelligence is good if it's intelligent. If it's, sometimes it may be dumb, but that's what my point. And there are other things, but thank you, because we all in our department used to give some data to the big data. I think in all over the world now they are going to collect all these big data, and surgeons like you, excellent surgeons, are going to even tell the machine how to put the screw in the future. And I think it's very, very much important. Horizontal gaze in the patient is very important. Also, if we don't see the patient like that, we ignore all these deformities. We don't like to operate, but horizontal gaze is not only a gaze. It means that the patient cannot eat. It's a terrible thing. It's going to be a disaster. And the key slot technique is perfect for the pedicle screws. And I totally agree with you, but it all needs some experience. And what I want to say, I think you routinely use neuromonitoring in all these cases. Am I right? And
yeah, we do use neuromonitoring, and I didn't have time to go into that. You might say, okay, why is your nerve root injury rate so high when you use neuromonitoring? I have a really good answer for you. It's because the neuromonitoring doesn't pick it up. Actually, unfortunately, the sensitivity of multimodality monitoring. So we use transcranial motor evoked potential, we use somatosensory, we use EMG, and on more than 95% of the cases where we had a C8 palsy, the neuromonitoring was completely normal. Mm-hmm. So for some reason, transcranial motor evoked potential monitoring is great for spinal cord monitoring. It is terrible for nerve root monitoring for osteotomy. And actually, we are now experimenting with using machine learning to improve our nerve root monitoring. So we're actually starting to use machine learning in neuromonitoring.
Yeah, thank you. And the cases were brilliant, but there are many questions. One of them, I think you have already answered. My dear colleague Ihsandan asked what screws you prefer, the pedicle or the lateral mass. I think lateral mass screws are not so biomechanically powerful enough, but the other Kemal you just saw from Izmir, our professor, also my good friend, asks, where is our boundaries? I mean, he wants to, probably, there are many cases now coming to us because the life expectancy is becoming more and more longer, and the patients are more suffering from being incapacitated because of their aging spine. So how do we calculate it? The machine learning will tell us which cases are going to be a good candidate for surgery in older age. I think is wants to ask, maybe we have cases like 90 years old. I am sure you have much more experience than us in the United States, with wheelchairs, with all these, motor cars. And what can you comment about it? What's our boundaries?
Yeah, and I fully agree with your first point that you made in the question session, which is that there's no replacement at all for the humanistic aspect of medicine. That will always be a human-to-human interaction. But the machines and the data can give us some information. So in terms of deciding where the limit is, it's useful information to have the most accurate prediction of outcome. How much better are you going to make this older patient, where age is a component of the calculation? And then the telomeres give us useful information, because what if you have a 90-year-old patient or an 80-year-old patient that has very, very short telomeres, that patient may be not likely to live much longer. And so putting that patient through a big procedure where you're seeing a likelihood of MCID that's quite low, that's going to be useful information that you can't necessarily have in a human-to-human interaction without this type of additional data. But if you see a 70% chance of MCID, and you see that patient has the telomeres of a 60-year-old, I think you're going to be more likely to offer that patient, a more extensive operation or an operation. And then maybe you would use some of your research and your techniques to bring minimally invasive surgery more into the calculation. That's one area that we really need to improve upon in our data registries. It's the incorporation of minimally invasive surgery, so we can figure out what's best for that older patient that you're saying is kind of at the limit of who to treat.
Thank you. And may I ask, are they all? Can you hear me, Dr. Kahraman and our dear friend, Dr. Alana? is the president of Eurospine, and Serdar is also our good friend. He has been in the many positions in the Eurospine as well. Are you online? Can you hear me? Would you like to make some comments?
Yes, I am here.
Yeah, yes, Serdar, Dr. Kahraman.
So it's very interesting that
and there are many comments also coming for me. But Chris' amazing lecture and his these challenging cases now are very much, I think, helpful for us. And the techniques briefly and openly makes us understand why we should do surgery safe. And thank you, Chris, for this. I mean, these videos were excellent. Serdar is also very experienced in cervical region. So, yes, Dr. Kahraman, what do you think?
Yes.
First, machine learning and then the cervical deformities.
I want to ask the cervical myelopathy cases. So we know that first of all, I agree with Dr. Chris. Not only the decompression alone is enough to treat this kind of cervical myelopathy cases who had a cervical deformity. So it also required a kind of deformity correction. But I wonder that even in some cases we had some deformity corrections, still we have a kind of neurological deficits. So the Dr. Chris said that if you don't have any deformity correction, then the spinal cord still under the pressure. So is there any further comment about that?
Yeah, that's a very good point, in that the cases that we're talking about that have severe compression and also have deformity are oftentimes the highest risk cases. And to try to figure out how much extra risk you take, neurological risk you take, to improve their neurological function is a very difficult calculus. I think it really has to be considered on a case-by-case basis, and probably considering a bit the health of the spinal cord. So somebody that has significant spinal cord signal change, or someone that has really a significant myelopathy where the spinal cord has been damaged, chronically damaged, probably less likely to tolerate a riskier surgery. But that's a clinical judgment for now. Maybe in the future, some of our data will tell us, how much risk to take. But your point is well taken. They are the cases that maybe could most benefit from that are also the cases that have the highest risk when you're doing more aggressive surgery, I think was the point you were making, and I agree with it.
Okay, thank you. And the other question is about the machine learning prediction of the kind of surgical complications. So as I understand from your lecture, the telomere length is more important than the frailty index. Is it true? It's very interesting to hear that kind of parameters, yeah.
That's what we found in our first series of, I think there were 43 patients. That's not a large enough series to draw like long-term conclusions, but certainly in our early series, telomeres were more predictive than our frailty index. I didn't go into some of the newer work we're doing on epigenetic information, but it's interesting that some of the epigenetic clocks, there's one called Dunedin Pace that was developed out of a US company that was originally formed to do racehorse performance, of all things. But this clock, Dunedin Pace, that they have the rights to, is really linked to our ASDFI. So for the first time, we submitted this to SRS this year. For the first time, we found a genetic clock that's very linked to the adult spinal deformity frailty index. So we're trying to find the genetic representation of frailty. Probably in the future, I think that these clocks will make their way into our prediction algorithms, and We may develop even better tools that are more predictive, better frailty indices that may include some of this, or maybe there will be a laboratory test that will completely replace some of the data points that we're collecting.
Okay, thank you, Chris. Thank you.
Thank you. Dr. Alanay, can you hear me?
Yeah, I can hear you. Hi, Chris. It's great to see you.
Hi, Ahmet. Great to see you as well. I miss seeing you in person.
Yeah, hopefully soon. Well, actually, I had to run 2 meetings together, and I missed some part of your talk. Those were great talks as always. So maybe I can ask a technical question about artificial intelligence, as being one of the guys involved in this and doing studies together with you. So one problem that I see is, we are actually, our treatment methods are changing really very fast. And once we start, collecting data, so how long do you think the follow-up period should be, or how new it should be for the patients that we are treating in spine surgery to do AI studies? And the second thing, this is something that we also had some problems, but you have, let's say, 700 data items, and then, once the machine has learned all of them, then we start to look for new data items, to have better analysis. So how do you think we can solve these problems, and how do you think about these problems for AI studies in spine surgery?
Yeah, I just want to say initially, I really enjoyed working with you on these topics, and our collaboration with the European group has been, so critical. This is work we've done together. So you're privileged to know that the main issues which you just raised. So the first issue is absolutely a real issue. And I think to some extent, Ahmet, it's an issue of scale. It's like, even though the ISSG and the ESSG are the largest registries, we can only accumulate patients so quickly, and yet our practice is still transforming. So probably at any point, we're only going to have 1,000 to 2,000 patients that are really representative of the current practice that we're doing, and our current complication rates. And we're always, thankfully, we're always getting a bit better technically. So to me, if I think about it, probably we need more patients coming in a shorter period of time that represent, a similar practice style and a similar complication profile, if we're ever going to get, even more accurate within that sort of narrow window. There are statistical techniques, as you know, where you can weight more proximate data, and this is used all the time, on Amazon and some of these online, Facebook, where they weight. They temporally weight data. So data that is 1 to 2 years old is given a higher predictive weight than data that's 5 or 10 years old in terms of predicting the risk or outcome. That's a huge problem. I think it's a problem of scale. We would love to be able to trust the data enough of 100 sites to include all of them in the models we make, but unfortunately it's hard to do data verification. So some of it may be that we expand ISSG and ESSG a little bit. Some of it may be that we apply better statistical techniques, to the weighting. The new variables is a huge problem too, because of the way the study groups operate. We have to form these unified IRBs with unified data points, and we commit to that for a certain, period of time. And we're not as flexible as our university systems, where we can come up with an idea and within a month we can have a new IRB. So maybe the answer there lies in some flexibility, maybe forming pilot groups within ISSG and ESSG, where there's certain sites that say we want to be sort of a data testing site for genetic aging or new variables, and we move more rapidly than the larger groups. It's like an alpha testing subset sort of the busier, more academic sites. Some sites are great just to add data points. Some sites, like certainly your site, my site, Farhan's site, they're better at, maybe testing new things, or new development. So there might be some way to work, within that system.
Great, thanks.
Thank you, Dr. Alanay, and thank you for also giving some time for us. But I think a good collaboration, Chris, is very essential in the future. But I'm afraid that he's going to measure my telomere length, and I don't want him to do it. But if you are not tired, Chris, there are many questions coming. One of them is about osteoporotic cases. Do you use cannulated screws? The other is about the paraspinal muscles, and they are, I think, sometimes going to atrophy, and for the, of course, redo cases, I think. And our good friend, Cüneyt Temiz from Eastern also asks whether the myelopathy can be reversible. You know, in many cases, they are not reversible. And finally, I don't want to take your much time. In the very early time in the United States, you are very kind to give these lectures for us, but you don't go to occipital bone, I think, in many. And do you need, in some cases, for the severe deformities, sometimes C1, C2 fixation fails. That was my experience. What do you think about these points?
Yeah, maybe I'll lump the questions, you know, around the bone and the muscle together, and give you, you know, a practical answer, which is yes, we use vertebral augmentation. We haven't used a lot of cannulated screws, but we do use vertebral augmentation in patients with compromised bone, and actually we use it routinely in every thoracolumbar case for our older patients. But maybe give you a taste a little bit of at least what I think is going to be the future. When I think aging research is going to become a core part of surgery, and we're going to have a field essentially where we're, you know, surgical geriatricians. It's going to be surgical genomics, and essentially what we realize when we start to collaborate with some of these companies that have done a lot of aging research is that they're starting to type patients in epigenetically into bone agers, soft tissue agers, connective tissue agers, immune agers, and all these genetically based or epigenetically based phenotypes probably require different treatments. So for example, there may be some bone agers that are really old bone-wise that look pretty good skin-wise. You wouldn't know it. And they require a different treatment approach, or there may be muscle agers that no matter what you do to their spine, their muscles are so weak that they're never going to do well. And they may require hormone supplementation, nutritional supplementation, or other things to see whether their bones, you know, can be optimized. The other thing, and to try to make it, you know, more AI based, you know, I think what we've found is that the current, you know, JOA classifications for myelopathy are insufficient. And even though we do know that, you know, many patients with even severe myelopathy can improve, we're probably not classifying those patients very well with these sort of Delphi-based classification schemes, and utilizing more sophisticated data, for example, where we look at maybe some electrical data, we look at some performance-related data that's objective, and maybe we even look at, you know, which spinal cords are very blood pressure sensitive versus which aren't. These may help give us better delineation of different subtypes of myelopathy that are more likely to improve with surgery versus those that were not likely to improve. So I think, again, data techniques are going to help us to cluster and chunk these patients in ways that are going to be very helpful for us in the future.
Yeah, that's very important. I think you make the point. Genetics will also sometimes going to help our surgery, not only in chemotherapy or in other, you know, medication, but surgeons shouldn't neglect it, shouldn't ignore these facts. Some genetics are very important, and that doesn't going to be like an enemy to surgery. Sometimes it's going to help the surgery. And we together sometimes discuss what's minimally invasive, what's not. I think these all depend to one of the most important factors to the surgical technique is the genetic reservoir of the patient's bony, neuronal, and even sometimes the intelligent EQ, IQ. These are all going to be important.
Totally agree. Totally agree.
And Chris, do you go to occiput sometimes? Occiput is my very sensitive point. I put many screws there sometimes. That's what me.
The occiput is a very good bone, and it's definitely a better bone for fixation, especially bicortically with keel screws than even bicortical C1 or C2 pedicle screws. We go occasionally. We try to spare it if we can to just give us a little bit of, I would say, degree of freedom for the patient to tip their head in swallowing and to leave them a little bit of freedom for their head movement. So we avoid it when we can, but in cases where they failed or, some of the cases where we have C2 to pelvis fusions, these patients fall and break their odontoids. We have to go higher to the occiput. So we've even experimented with, and I'd be interested in your opinion on this, since you do a lot of occipital fixation, is we've even experimented with temporary occipital fixation, where
that's what I'm studying. But we'll see. I think it's going to be a salvage type of surgery, and then temporary surgery. You're always there. I don't want to take your time. You are tired, and you're very kind. I think if you also. We really appreciate to see some of your surgical videos in spine tumors, just maybe a few cases, and then sure. I think you're going to be in the surgery or somewhere else. It's I think now coming to the noon in the United States.
You tell me maybe 15, 20 minutes. Is that how much do you?
Yeah, that's 15, 20 minutes is okay. Thank you.
Okay, sure, okay. All right, well, this is really more of a fun one, not a lot of data, but it allows me to make a point. Probably the most important point about this is really where, a little bit about my career and where things have gone. I actually came from the world of primary tumor. I received a lot of primary tumor training in my residency and some in my fellowship. And so when I came into complex surgery, it was actually through bone tumors. And one thing that I found was nowadays metastatic spine tumors really are much more of a multidisciplinary problem where there's a lot of radiosurgery going on. The oncologists have kept a lot of the breast cancer patients and kidney cancer patients out of our clinics. And primary spine tumors have remained sort of the realm of the technically very experienced surgeon. And this is what I really found going on, at least in the United States, and I'd be interested in the perspective from Turkey. I came from tumor, but there are not enough primary tumors to keep me busy. So I sort of took my primary tumor skills and went into deformity surgery. And I think we're going to see sort of the combination of these surgeons where because the techniques that we use for deformity are very, very similar to the techniques we use for primary tumor and vice versa. If you can do a very complex 3-column osteotomy, you can do a primary tumor en bloc resection. And it's very hard to keep somebody employed like Zia who only does primary tumor. There's just not enough of them. So these guys can also do deformity surgery. And on the other side, we're going to have our endoscopists, our minimally invasive surgeons, maybe our MIS metastatic surgeons. And that's where I think things are going to go in the future in terms of how we set up academic programs and who does what. I'm going to discuss sort of our techniques, and I'm going to go via histology and show you just a little review of how we treat a lot of the primary bone tumors. And if I have time, I'll show you some of our new P32 work. Starts out with one of our most common tumors, which is the hemangioma. We've been seeing not only a lot of the grade 1s, which don't need treatment, and the grade 2s, which sometimes will benefit from a vertebroplasty. We've been treating some of these very aggressive hemangiomas with intralesional vertebrectomy and complete excision. And be careful, I would say to the younger surgeons on the call. I published this paper very early in my career, and now I have way too many aggressive hemangiomas coming into my clinic. So yeah, when you publish something, be careful because those patients will find you. But this is one of the first contributions I made to the tumor literature many years ago. Osteochondroma is a benign but can be symptomatic type of tumor that we treat with marginal excision. Here's an example of this type of tumor. This doesn't require any significant amount of bone resection. These are usually dorsal and very easily resected with complete en bloc resection. Osteoid osteomas treated with intralesional curettage or RFA typically. If they require treatment, they can lead to some scoliosis. Moving up, the aneurysmal bone cysts, we typically try to treat with serial embolization or even intralesional embolization. Sometimes we've been treating these with denosumab, but in the ones where we can't avoid surgery because of mechanical instability, we stabilize these with intralesional resection. Here's one from many years ago I did, and there's her holding her model of her cage. We can also do this in the cervical spine. I know that's an interest of this group. This was a case of an ABC that involved the C1 lateral mass with complete destruction. And we published this paper where we couldn't do embolization because the blood vessel supplied the spinal cord, where we did the first replacement of the C1 lateral mass with a cage and screws into the condyle to secure the cage with occipital fusion, as we just discussed a few minutes ago. For en bloc resection, these are usually applied for the stage 3 benign aggressive, more commonly to the stage 1 low-grade malignant tumors such as chordoma. And we use the WBB staging mostly to figure out how to deliver the spinal cord from the specimen. I'll talk about that thinking in a minute and show you the different techniques we use. We rotate this over so it looks very much like the image of the spine we're looking at on our MRI scan and our CT scan. It's a useful technique again for planning to just kind of rotate that into the way you're looking at the image. Osteoblastomas represent the type 3 benign lesion. They have a 20% recurrence rate with intralesional resection. We recommend en bloc excision for these when possible, and sometimes they can have an associated ABC. Here's a case where we did en bloc resection for this using navigation, where we plan the osteotomy and execute it using our intraoperative navigation technique. Here's a video. We dissect around the front of the spine to clear the vessels. We place the retractor arms to keep all the major organs and vessels away from the spine. And then using navigation, we make our cuts in the bone. I'll just show you kind of how we navigate it. So we have a very big spoon going in, a malleable retractor, and then we have a rod stabilizing the spine. We're going to apply a little bit of distraction to that rod before we actually remove the specimen. But here you can see us removing the specimen from around the cord. So again, if you can do this type of surgery, you can do any type of deformity correction, and I think vice versa. So that's why I think, from a specialty standpoint, this is where we're moving. We don't have enough primary tumors to keep the primary tumor surgeons in good practice, usually at any major center except maybe Zia or maybe MD Anderson. We can even treat recurrent tumors this way. This was a recurrent giant cell tumor that was treated in China in a software engineer that flew out to see us. And the options for this case, we did a standard posterior osteotomies and then anterior resection of the specimen. Sometimes your hand is your best tool. Get the specimen out. And here's a picture. We resected it with the cage still in place, and the specimen as a single piece. Actually, this patient had negative margins, and we treat these patients with denosumab as needed if they have any element of recurrence, which he hasn't so far. Now to talk a bit about the malignant tumors, the chordomas, and the osteosarcomas. This was a patient that had a aneurysmal bone cyst versus giant cell tumor versus telangiectatic osteosarcoma, which can look very similar. We weren't sure what it was. The biopsies were controversial, and so we treated this patient with the denosumab, and it started to look more like a telangiectatic osteosarcoma to our radiologists, and so we treated this patient with a combined anterior and then posterior release. This patient had a segmental vessel that was actually feeding the spinal cord. Here we see the distraction in place. And this case is a good description of how do you access this contralateral nerve root when you're doing an en bloc resection and the tumor is completely in the area for exposure. Basically, we access the contralateral root by moving the specimen more laterally away from the spinal cord. So this is also the way that you access the ventral component of the specimen, is by mobilizing the specimen, pushing it down, pushing it laterally, and then things that are covered initially by the tumor itself can be exposed enough for resection. And here's just an example of the specimen coming out from around the spinal cord. You can see we use the racks even on these primary tumors. We very carefully lift the specimen out from around the cord. You have to make a lot of room in the soft tissue windows and muscle in order to do this, to be able to pull it laterally enough to get it out, and then just a little bit of resection of some of the soft tissue attachments before it comes out completely. For chordoma, this is the most common utilization or indication for en bloc resection. We typically do posterior single stage for the high thoracic lesions, and then for the lower thoracic and thoracolumbar lesions, we do posterior anterior typically to remove these in two pieces. And I think it's always interesting to see video. We've made kind of a video library of our primary tumors. This is something we wanted to do for education because, you know, when you go to meetings, a lot of times you just see pictures and it's really hard to know like how the surgeons actually do these cases. This is a case showing the utilization of the thread wire saw for this chordoma. This patient actually had prior multi-level laminectomies for an epidural abscess about 30 years ago, and then presented with a chordoma. We pass the thread wire saw, we do the finger dissection, like you're seeing here, and then we make the cuts through the discs. And I'll just show you the video. We use the Tomita saw guides to stabilize the saw in the proper position. These are two attending surgeon cases, obviously. Cutting toward the spinal cord, so we have to be a bit careful. We don't come all the way through, except under very controlled. We've already cut the disc a bit with a knife, so the last bit we don't have to come all the way through. You can see the spoons, the Tomita spoons in place, and then we actually use. This is something where deformity is educating the tumor surgeon. We use a central impactor that we use to break the middle column for our 3-column osteotomies, to push the specimens out. So again, tumor and deformity as a single specialty, I think are really good. Again, you might get one of these cases every few months, and you have deformity every week. So it's the deformity surgeon that probably is going to take these on. I know Cal Kabesh also takes these on, and it's certainly something that is easily within the purview. And here's the specimen and multi-rod reconstruction for this case. You can do 3-level all posterior. Really, there's no limit. Here's just some pictures of this case. In the interest of time, this patient had significant epidural involvement, and we put the racks in place. Again, made the cuts in the bone, and finger dissection, top and bottom. Here's an interesting technique that we use sometimes where we really want rigid fixation, a little bit more rigid than the rack, is we'll use this looped rod to get it out of our way. That can be very helpful for the tumor resections, and then making the cuts in the bone, and then the resection. It's very helpful to apply some distraction to the rod when you're lifting the tumor out. It helps to open those cuts you've made in the bone. And here's a three-level resection, and then the reconstruction. And then a 2-stage chordoma. Again, this is a patient with the thoracolumbar junction. So with the diaphragm, it's a little bit more complicated. Very large tumor abutting the aorta. So we did a posterior approach first. This is just to kind of show you the different steps for this, where we thread the thread wire saw through the silastic sheath. I just don't know if anyone's ever seen like the full video of all the different Tomita techniques. This is the passage of the saw. It's a little bit blurry, but you get the idea. With laminectomies above and below the levels of interest, and then passing the sheath, and then passing the saw. And then we make the cuts to remove the dorsal elements. And then we lift up the lamina as a single piece. We would bone wax any area of the pedicle, or fill it with a fibrin sealant or bioglue to prevent any tissue, any tumor tissue from coming out. And then making the posterior cuts, passing the membrane between the dura and the vertebral body. And I'm keeping an eye on time. I'm just going to go another 5 minutes to 10:15. And here, this is a good landmark when we come in from the front. So we find this membrane, and it's we can go pretty quickly. We know we're safe, and this helps us to prevent any sort of dural injury when we lift it out from the front. And then we've dissected the specimen really anteriorly as well, and it's ready to lift out completely free. And you see the membrane still kind of stuck to it there. And so that whole thing will come out now. And it's a 2-stage around the diaphragm. We can even do this up to 5 levels. This patient, the issue with 5 levels is really the vascular supply of the spinal cord. So for this patient, we wanted to try to only do the levels that were actually infiltrated by tumor. So we applied preoperative radiosurgery to this patient to treat the any sort of planned transgression in these areas where we weren't planning the en bloc resection. And you usually take up to 3 levels fairly safely. More than 3 levels is higher risk of vascular compromise of the cord. So we did preoperative radiosurgery, and then multiple posterior, then multiple thoracotomies for resection. And here's the anterior osteotomy and the posterior resection. And that's just our thoracic surgeon there taking it off the esophagus, some soft tissue attachment close to the esophagus, and the specimen lifted out. Again, just possible to do it all as a single piece. And I'll finish up with this case. We can even apply these principles to the cervical spine. This was our largest cervical tumor that we've done to date, with right-sided full encapsulation of the artery, left-sided abutment of the vertebral artery. We do preoperative sacking of the vertebral on a level of involvement. And obviously, we have to target our whole surgery really to preservation of the one remaining vertebral. And for this case, we did posterior first, and then we did anterior. The anterior, we used this bilateral transverse cervical exposure, where we literally came in alternating on both sides. And here's the posterior operation, which we did first. We tied off the nerve roots there at 3 and 4. There you can see the remnant of the vertebral artery and the clips. One very important point is don't cut the artery on the side where you're sacking it, where they put the coils, because you'll pull the coils out and the artery will still bleed. So they have to coil it where you're not going to sack it. That's very important. And we dissect the ventral surface. We're going to place a membrane as well in this case, and 4 rods. And then the one remaining vertebral artery you can see here. We've completely separated it from that. And then we're completing the osteotomy here on the contralateral side, on the left side. And then we'll deliver the tumor from the left side. And you can see the complete resection is a 4-level vertebrectomy, complete with the coils in the vertebral artery. And this patient, I'll finish with this in terms of predicting outcomes and talking about patients and their pain. It's a true story. This patient, her VAS neck pain score was 1. So I can't make sense of that, but that's an honest reporting of her neck pain score. And it just shows you that so much of calculating patients' outcome, pain, has to do with aspects of patients' personalities and less so maybe to do with the surgeries that they've gone through. So I really appreciate the time that we were able to spend together today. And thank you, Professor, for the kind invitation. And it was so great to see my friends Ahmed again and make some new friends. And it was a real honor for me to present this year at your wonderful symposium.
Yeah, thank you, Chris. And on behalf of many my colleagues in Turkey, and I think there are many other colleagues from South America, Asia, from Middle East, they made good comments, and they all thanks and appreciates your presentation, your lectures. We really enjoyed it, and you, as I always say, new horizons. We should keep trying to find new horizons. I think we have many new horizons after your lectures, and the cases, of course, Ziya, you mentioned Ziya's cases after stabilization has no chance to go on for deformity in the future. Yeah, I know Ziya very well, and our other friends, the Vedat Turkish friends, I know you are good friends. But thank you for mentioning them. And I hope we are going to make the next one face-to-face, and probably in Turkey. And in Turkey has many good places. And I think you won't regret leaving San Francisco if you come to Antalya and Cappadocia and other places. I don't know, these cases has many tricks, surgical tricks, but we don't have time, and I don't want you to have your more time, because I know you are very busy, and you are very kind to spend all the morning in the United States now with us. Thank you very much.
Pleasure.
And I hope to see you in the future. We are going to meet together, and I hope we are going to work together. And I would also like to thank Ahmet Alanay, our dear friend and president of the Eurospine, and our other dear friend, Serdar Kahraman, and for their help to me. Thank you very much. And
thank you all very much. Thank you so much. Have a great day. Have a great evening.